afternoon. I'd like to thank the organizers for the opportunity to talk to you today about precision oncology for stage 4 melanoma patients in 2021. These are my disclosures. The last decade has obviously been very exciting in the field of stage 4 melanoma, with 12 new regimens approved for patients with metastatic disease, a real balance of both immune therapies, which all metastatic melanoma patients are eligible for, and targeted therapies for stage 4 melanoma patients with a BRAF V600 mutation. And over this time, we've seen median survivals improve from 6 to 8 months to perhaps 2 years or even greater. And with all of these new therapies, again, this is tremendous progress, but there's also a need for how can we guide rational decision making to optimize the treatments that each patient receives. So with that, it's my pleasure to talk to you today about several advances, and particularly what are the biomarkers that have emerged to help guide decision making in the management of stage 4 patients. So first, I'll talk about our approved immunotherapies and the key question of who should get single agent PD-1 and who should get PD-1 in combination with CTLA-4, a new player, anti-LAG3, and then finally to talk about BRAF mutant patients, and particularly the question of targeted therapy or immunotherapy. So let's talk first about the current status of immunotherapy for patients with stage 4 melanoma. So here, really sort of the benchmark trial in our field was the Checkmate 067 study. And this was a randomized phase 3 trial in which patients with treatment-naive metastatic melanoma were randomized evenly to treatment with the Ipi-Nivo combination of Ipi at 3 mg per kg or Nivo 1 mg per kg, single agent nivolumab at 3 mg per kg, or the control arm for both of the other arms, ipilimumab at 3 mg per kg. And this is a study that we've looked at really almost annually for updates, and really trying to tease out both the results of this study and trying to understand who really are the patients who really benefit the most from each of these therapies. So this is the update that was presented by Jed Walchuk at the 2021 ASCO annual meeting, and this is the overall survival for the 3 arms of this study. And what was sort of notable was that we finally have a median overall survival for patients treated with ipilimumab and nivolumab, an unprecedented number of a median overall survival of 72.1 months, or just over 6 years. Really something that again reflects how far the field has come. As we can see here, many patients treated with single agent nivolumab also do quite well, and indeed at 7 to 8 months of follow-up, the absolute difference in overall survival between Ipi-Nivo and Nivo alone is relatively modest 7%. However, certainly both of these treatments result in much better survival than seen with single agent ipilimumab at 23% at this long endpoint. However, I would point out a result that is very consistent with previous studies about long-term survival with single agent ipilimumab. I think it's also important to keep in mind as we look here at the updated data for progression-free survival that although these overall survival numbers again are really spectacular, it is still the case that many patients will progress on both Ipi-Nivo or Nivo monotherapy. And looking here at the 48-month progression-free survival for both, it's sort of in the 30 to 35% range. And so again, in many patients, we start with these treatments, but often have to ask the question of what should really be given in the second line. Again, these results are really spectacular, and there really wouldn't be much of a question of what therapy to give if the toxicities of these regimens were equivalent. But again, as we know, the toxicities of Ipi-Nivo are much greater than those seen with Nivo alone. As we can see here, about 60% grade 3 to grade 4 treatment-related adverse events, with approximately 30% of patients stopping treatment with Ipi-Nivo because of toxicity. Again, much lower numbers for single-agent nivolumab. And really the question becomes, can we really determine which patients need the combination and which patients need single agent? And ultimately, our question for the field, can we achieve high rates of durable response but with less toxicity? So several analyses have been done looking at Checkmate 067 to see if we can differentiate who really gets the most benefit from the combination. And I think there's really sort of two interesting and potentially compelling findings. First, here from the 2021 presentation is looking at outcomes by BRAF mutation status. And so what we can see on the left are the outcomes, particularly overall survival, for patients with a wild type BRAF gene, about 50% of our patients. And what we can see here is that when we look at overall survival or progression-free survival, the difference in outcomes between ipi-nivo and nivo alone is really quite modest. However, to the right, for patients who have a BRAF mutation, we see a real separation of the curves with really what seems like a much more marked benefit for ipi-nivo versus nivo alone among those patients with a BRAF mutation. Again, a marker that we really assess in virtually all of our stage 4 patients. And so I think something to keep in mind as you make decision making about your patients. On this slide, we see the outcomes from the 5-year analysis by PD-L1 immunohistochemistry. This is a marker that really is not necessarily obtained on all patients, but I think in Checkmate 067 at least has shown pretty consistent results over the duration of the study. And in particular, I think the cutoff that is really sort of, again, most clear and potentially most clinically relevant is using a cutoff of less than 1% versus greater than or equal to 1% PD-L1 positivity on tumor cells. And so as we can see at the bottom left, for those patients who are PD-L1 positive, meaning having at least 1% of cells staining positively for PD-L1 expression, whether you're looking at progression-free survival or overall survival, we see very similar outcomes for ipi-nivo versus nivo alone. But in contrast to the right, for those patients that are PD-L1 negative, this is where we see a real separation and really a superior outcomes with ipi-nivo versus nivo alone. Now, again, I think that the data for both the BRAF mutation and PD-L1 is very interesting and consistent, but there's the caveat that each of these analyses that I've shown you are univariate analyses that can't really account for the other clinical features or molecular features that are present in these patients. And so I don't make decisions based on these markers alone, but I do think they're worth thinking about as you make your decisions about what you should treat with in terms of ipi-nivo versus single agent anti-PD-1. And certainly we hope that at some point in the future we will see sort of an analysis that brings all the different candidate markers together. However, I do think that the place where there is consensus for the superiority of ipi-nivo versus single-agent anti-PD-1 is in patients with active asymptomatic brain metastases. So here again is updated data from the ASCO 2021 meeting presented by Georgina Long from the ABC study, in which patients with asymptomatic melanoma brain metastases either received treatment with ipi plus nivo or with nivo alone. And what we can see here is truly marked differences in the outcomes between these two therapies. And I will note that the outcomes seen in this study with single-agent nivolumab are very similar to those reported previously in patients with brain metastases with single-agent pembrolizumab. And so in both of those studies, treatment with single-agent anti-PD-1 achieved intracranial response rates in approximately 20% of patients, whereas patients with asymptomatic brain metastases treated with ipi-nivo have seen response rates in the 50 to 55% range. And as you can see in the curves on the right, at the top for progression-free survival at 5 years, there's an absolute difference of 31% with better outcomes with ipi-nivo, and down at the bottom right, an improvement in overall survival at 5 years of 17%. Much larger differences than were seen in the Checkmate 067 study that excluded patients with brain metastases. We do know that both of these regimens are less successful and less active in patients with symptomatic brain metastases and may not be the first-line treatment for them, but for patients with asymptomatic brain metastases, I think the data is very compelling about the degree of benefit and the duration of benefit we see with the ipi-nivo combination, and thus the treatment we use most commonly in those patients. Now, as I said, we continue to look for new immunotherapies and immunotherapy combinations that can be active but safer. And we heard at the ASCO 2021 meeting the first efficacy results from the Relativity 047, a double-blind randomized phase 2, phase 3 trial in which treatment with single-agent nivolumab was compared to the combination of nivolumab with relatlimab, an anti-LAG3 antibody, in patients with treatment-naive stage 4 melanoma. And as Dr. Lipson presented, the exciting finding was that the clinical trial met its primary endpoint for an improvement in progression-free survival. We can see here the hazard ratio was 0.75 with 1-year progression-free survival rates of approximately 48% for nivo-rela versus 36% for nivo alone. And while those absolute percentages are slightly lower than what was seen in the Checkmate 067 study, and we can discuss the reasons for that, the hazard ratio is actually very similar, as is the absolute difference between the two treatments at this time point. And what's been really important about the results of this study is that nivo plus relatlimab had a toxicity profile that was essentially very similar to single-agent nivolumab alone, so an improvement in progression-free survival without really much of an increase in toxicity. Now, what about biomarkers for benefit from this regimen? And so here we see the outcomes from Relativity 047 by LAG3 expression. And the take-home message is that LAG3 expression does not appear to be a biomarker that identifies which patients achieve benefit. Indeed, very similar benefit, very similar hazard ratios for nivo-rela versus nivo alone, both in the left on patients with LAG3 expression of at least 1% versus those on the right with LAG3 expression in less than 1%. So it doesn't appear that LAG3 is likely to be a marker that we use in the future to pick which patients should be treated with the nivo-rela combination. And indeed, somewhat reassuringly in the presentation by Dr. Lipson, an exploratory analyses looking across multiple different clinical variables, in almost all groups, we do see benefit for nivo-rela versus nivo alone. But I do think the one potentially interesting biomarker was again the results by PD-L1. And what we can see here, as shown in the table, is very similar difference with the nivo-rela as we saw with ipi-nivo. So in patients with PD-L1 less than 1%, the hazard ratio for nivo-rela was 0.66, actually identical to the hazard ratio for ipi-nivo. And as we can see in contrast for those patients with PD-L1 expressed on at least 1% of cells, a hazard ratio of 0.95 for nivo-rela versus nivo. And in addition to saying, does this actually help us in some way pick which patients should be treated with this combination versus single-agent PD-1, I think it also raises the question of whether nivo-rela is actually rescuing the same patients that the ipi-nivo combination rescues, or will they actually be non-overlapping such that there'll be value to using these combinations sequentially? Indeed, a question that we'll be very interested to see moving forward. But again, an interesting finding, I think, from this study. So let's move to targeted therapy for BRAF mutant melanoma patients. And here we have 3 different FDA-approved BRAF MET combinations: dabrafenib trametinib that was approved in 2014, vemurafenib and cobimetinib approved in 2015, and encorafenib and binimetinib approved in 2018. And over the last couple of years, what we've been fortunate to have are updated results that now give us at least 5 years of follow-up from each of these trials. And I would say that, again, what we see consistently across the studies is very high upfront activity with response rates in the 70 to 80% range, and perhaps most importantly, disease control rates in our BRAF mutant patients in the 90 to 95% range, indeed higher than what we see with either single-agent PD-1 or ipi-nivo combinations. However, again, the great thing about our field is that as our treatments have improved, we've begun to focus not so much on just what those early results are, but how durable are our responses and how many patients are not only long-term responders, but potentially cured by these different therapies. So this slide presents updated summaries of both the progression-free survival in the upper left and the overall survival in the upper right for the phase 3 studies of each of our approved combinations. DT is dabrafenib trametinib, VC the vemurafenib cobimetinib, and EB the encorafenib binimetinib. And again, we can see that the median PFS ranges from 11 to 15 months and the median overall survival from 25 to 33 months. And although it's tempting to try to say that these differences mean that one combination is better than another, it really is sort of dangerous to make those type of cross-trial comparisons, as we recognize that the risk profiles of patients in these different trials was actually quite different. I think for me, the take home is when you look at the long-term data, the 5-year PFS and the 5-year overall survival, those actually look quite similar across the clinical studies. And although many people have felt that it's not possible to achieve long-term responses with targeted therapy, we can see in each of these studies a subset of approximately 20% of patients who at 5 years are alive and well and still responding to these therapies. And so again, the graphs at the bottom show the 5-year PFS for dab-tram on the bottom left and the 5-year overall survival rate on the right, which again is in the 30 to 35% range. And so with targeted therapy, I would argue that right now the continuing question we have is how can we identify those patients who are most likely achieve these very favorable long-term outcomes? So there are some clinical predictors that we have. Really, first is that patients with a lower burden of disease do better. And I show here in particular the data by serum LDH, which highlights the finding that we've had across all of our studies, that patients with high LDH tend to have poor outcomes. With targeted therapy, these patients still get responses, but it's very rare for them to be durable. The other thing that really predicts long-term durability is whether patients achieve a complete response to therapy. And so as we can see here down at the bottom in the 5-year analysis of dabrafenib and trametinib, for those patients who achieve a complete response, 50% of those patients remain progression-free at 5 years. And so although with targeted therapy, even in responding patients, we often consider, should we add immune therapy or switch to immune therapy? I think for patients who are tolerating the treatment well and achieve a complete response, it's really worth thinking about, again, continuing on this therapy because maybe we are curing those patients. Again, the challenge is how can we differentiate those who will or won't have that long-term progression-free survival, and more importantly, are there early predictors of who those patients are? And with that in mind, I think an emerging interesting area of research for targeted therapy is the role of ctDNA. And I would really highly recommend for those of you who are interested in this, a paper recently published by Dr. Polsky in Lancet Oncology, in which they performed digital droplet PCR to detect and quantify circulating BRAF mutations in the blood. And in particular, they had samples at baseline and after 4 weeks of therapy from the phase 3 COMBD trial of dabrafenib and trametinib versus dabrafenib alone. And what's shown in the upper right is the multivariate analysis looking at both progression-free survival and overall survival, showing that ctDNA, particularly its status after 4 weeks of treatment, was very significantly associated with both progression-free survival and overall survival. And I think what was interesting, as shown at the bottom, is where it seemed particularly able to distinguish between good and poor outcomes is in those patients with high serum LDH, much less so in patients with normal LDH. And I think what's intriguing about this data, other than potential implications for clinical practice, is whether we can use this in clinical trials to quickly identify our best combinatorial strategies. Finally, of course, for BRAF mutant patients, should we be starting them on targeted therapy or immunotherapy? In retrospective studies, consistently targeted therapy ends up having better outcomes at early time points, but at late time points, better outcomes with immunotherapy. However, with a potential bias in patient selection. So what we're really waiting for is prospective trial data. We saw the first such result at ESMO this year with the SECOMBAT study, which looked at 3 different sort of sequencing regimens. And very briefly, what I will say is that the patients who received encorafenib and binimetinib first and then switched to ipi/nivo upon progression, as opposed to the reverse of this, seemed to show trends for worse progression-free survival and perhaps overall survival, but with the caveat it's a very small study with about 70 patients per arm. But what we hope to find next year are the results for the ECOG ACRIN 1634 phase 3 study, in which patients were randomized to ipi/nivo followed by dab-tram if and when they progressed, versus starting with dab-tram and switching to ipi/nivo if and when they progress. And the investigators of this study were recently notified that the trial is now now close to patient enrollment based on having reached its primary endpoint. So hopefully a study will here in the coming year to provide definitive answer to this question. So finally, it's been my pleasure to talk to you today. We've had a true revolution in treatment options and outcomes for patients with cutaneous melanoma. We continue to have needs for molecular, immune, or clinical biomarkers to guide therapies, particularly validating markers for combination immunotherapy versus single agent, and I think a new need for markers for anti-LAG3 therapy, and finally, better predictors of long-term benefit from targeted therapy. And as you heard before, the ultimate question, too, of how many of those markers will be relevant and applicable to patients with earlier stages of disease. With that, I thank the organizers again, and I look forward to discussing this presentation with you.